Good evening, everyone. Thank you for joining us tonight as we begin part 2 of our Canine Osteoarthritis Diagnosis webinar series, Improving the Value of Your Radiographs. Tonight's speaker is Dr. Patsy Mich. Dr. Mich is a graduate of Colorado State University and has practiced in the Denver metro area since 1991. She is triple board certified by the American College of Veterinary Sports Medicine and Rehabilitation, Anesthesia and Analgesia, and veterinary practitioners. Additionally, she is a certified canine rehabilitation therapist and teaches at the Canine Rehabilitation Institute. Dr. Mich calls her work mobility medicine, and her job is to get dogs of all ages back in the game. We are also joined by Dr. Meg Green, technical service veterinarian here at Contura Vet, and she will be assisting with moderating our question and answer session at the end of tonight's presentation. Should you have any questions during the presentation, please use the Q&A box at the bottom of your screen, and we will address those at the end of tonight's presentation. Thank you again for joining us, and Dr. Mich, the floor is all yours.
Thank you so much, Amy and Meg. Oh, it's just a thrill to be here with you all tonight. I'm really excited about this presentation, mostly because of my experience as a general practitioner for many, many years. And went through trying to improve my diagnostic quality with radiographs. Full disclosure, in my practice, I had a very progressive owner who brought in a radiologist early. I'm old enough that wasn't standard. Anyway, he browbeat us. I kid you not, he browbeat us into taking better radiographs. So all my gratitude goes to him. He will remain unnamed, but all my gratitude goes to him for teaching me how to get the best radiographs I could. So with that, let's move on to the presentation tonight. I want to thank Contura Vet for sponsoring me to speak to you tonight, and we'll move forward with the beginning of our presentation. All right, so just a little bit on my affiliations, so you're aware. I am a member of the advisory board for Contura Vet, a senior faculty member for the Canine Rehabilitation Institute, where I teach canine rehabilitation to veterinarians and to technicians and to physical therapists, as well as occupational therapists. And I do own my own practice. All right, my objectives for you this evening are to help you understand what is the role of plain radiographs in diagnosing canine osteoarthritis. You're going to hear from me that it's an imperfect tool, but it's a tool that we can use and get a lot out of. I also want you to understand the standard and special views of looking at appendicular joints when assessing for arthritis. I'm not going to really touch much on the spine other than the lumbosacral joint, because so much of what we're going to see is going to be in the appendicular joints. And then finally, I want to help you learn how to take excellent images by avoiding common mistakes. So let's begin this by saying, I want you to think about the fact that often osteoarthritis diagnosis are made later in life when clinical signs are obvious, even without imaging. So this image that I have here circled in red, clearly that's an arthritic joint, and you're going to find that clinically, and your radiographs are going to prove that to you and help you decide that it's not something more nefarious like neoplasia or perhaps a fungal infection or something like that. So really obvious as time goes on in these patients. But you guys, most canine osteoarthritis is caused by congenital or developmental diseases that then progress. So look at this one where I've put the arrow. This is a dog whose growth plates have not yet closed. And yet there is sign of osteoarthritis developing with the white arrows. That's sclerosis of the ulnar notch. So I want to help you pick these cases up way before you have that end stage elbow. So early clinical signs with imaging are critical for early intervention. And early intervention is where we can have our greatest impact. When you get an end stage joint, boy, you guys, that horse is out of the barn, so to speak. What you're dealing with now is tremendous loss of cartilage. You've got synovial hyperplasia. You've got periarticular fibrosis. This is a diseased joint, and we're not going to get a lot of progress when we get that bad. So the key is to find this early. While plain radiographs are not the gold standard in diagnosing early OA, it's a great starting point. It's a tool we have in our hands in our general practices. So let's find out how to use it really well. So, wanting to give you a little bit about where we are in prevalence, especially in the younger dog. This is a paper that came out in 2024, and I want to kind of take you through it and talk about what I learned in reviewing this paper. So, take a look at this. In this paper, this was a single practice. They looked at dogs from about 8 months to about 4 years of age. 40 breeds were represented, and there were 123 dogs. In this graph, we've broken them down, or they've broken them down to less than a year and a half of age, a year and a half to about 2.5 years, not quite, 2.5 on. And then here in the last group, we have dogs at about 4 years of age and just under. When we look at the prevalence of dogs who have radiographic osteoarthritis, that's what the little R means here at the top of the image. These are dogs with radiographic evidence of osteoarthritis. These were the number of dogs in the age group on the bottom, and this is the percentage of dogs impacted by radiographic osteoarthritis. So in this younger group, 5 of the 25 dogs were impacted. 6 or 23% in the next group. Look at this, 47% in dogs who were under, just over, I should say, 3 years of age. That's 14 dogs out of 30 dogs. That's almost half. And then when you get to less than 4 years of age, we're over half of the dogs. 24 dogs were impacted by radiographic osteoarthritis. That's a lot in one practice. And they looked at 123 dogs, inviting clients to have a free review of their dogs. So when we add this up, there were 49 dogs affected. That's 40% of the dogs that came in to be reviewed that day. So what joints were affected? The usual suspects for younger dogs: elbows, tarsal joints, and the hips. Certainly we saw other joints, but those were the big players. What about how many joints did they find affected? I found this so fascinating. We had anything from single to greater than 5 joints. And certainly the vast majority of dogs in each age group had at least 2 joints affected. And because I'm a numbers nerd, I went and did some math about that. So that meant in the less than 18 months of age, there were 4 joints affected. 2 dogs, 4 joints. And then in the next group, 8 joints. In the next group, 12. In the next group, 24. That's dramatic. And then, because I'm a numbers nerd, I added up all the joints across singles through 5. There were 13 dogs, less than 18 months, or excuse me, 13 joints, less than 18 months. 13 joints. 10 in the next group, 30, and then 50. So that's a total of 123 dogs evaluated, normal group of dogs, and then in those 49 that were affected, so 74 that were okay, 49 not okay, at least 103 joints affected just in this small number of dogs. So much work can be done to help these patients. So I found this study really helpful for me as a clinician. The next thing they looked at is, well, what is the severity of disease? So this first slide shows mild joints along with radiographic evidence. And you see here on the right of the slide, this is the radiographic evidence in blue, the clinical evidence that the veterinarian noted in the red box. Yellow is the clients evaluating their own patient using these pain assessments scales, the snore, the CBPI, the load, and then the green is the treateds. Then they went and they looked at the moderates. So I put those two together, the milds and the moderates. And what did I notice? Well, the first thing is radiographs exceeded everything. We saw that across the board in each age group in both mild and moderate. I also noticed that the clinicians were not picking it up as much as the radiographs were, and especially the clients were not picking it up. They're not picking it up in the very young dogs. They're picking it up in the older dogs, but not very many of them. And then this was the most troubling to me. Look at the number of patients that were being treated. So we have all these patients with radiographic and clinical evidence of osteoarthritis, and only a teeny tiny percentage were being treated. There's so much room for us to improve that. That actually is encouraging to me. So what were their conclusions? Similar to mine. Radiographic OA is common in young dogs, and it increases as dogs get older. 60% of the dogs had mild pain along with their radiographic evidence in at least one or more joints. That was 23.6% of dogs overall. For moderate, 40% of the dogs with evidence of OA and 16.3% of the dogs overall, meaning of the 123. Other conclusions? Clients weren't so good at figuring this out. Radiographic evidence always exceeds the clinical signs. So that's a tool we can use. And then finally, again, as I mentioned, treatment lagged well behind both radiographic and clinical recognition of disease. So for me, I always look at takeaways in my studies that I review. There's a fairly high prevalence of radiographic disease in young dogs. And I, as a practitioner back when I was a GP, I was looking at more of the older dogs, and I should have been looking at the young babies too. We know it's progressive. If you have it as a youngster, you're going to just get worse and worse over time. And finally, the clients frequently miss the clinical signs, and therefore, we as veterinarians are a critical piece of diagnosing early disease and creating an effective intervention plan. Yet, I have to say, we fall short as well. So here's a couple studies that show where we fall short. So this is a study in 2024, again, looking at the prevalence of arthritis of shoulders, elbows, hips, and stifle joints in dogs older than 8. And this is a really messy table. I don't want you to get too deep into it, but I want you to notice these are the most common joints. And then here's our prevalence. Osteoarthritis prevalence was about 39% for the shoulder, 57% for the elbow. That does not surprise me. That's the most common joint I treat. 36 for the stifle. Actually, I missed somebody. 36 for the hip, and then for the shoulder, about 36. This one actually surprised me. I don't see nearly as much shoulder osteoarthritis in my practice, but still quite common. Now, this was 181 breeds represented, so it's not like we're blaming this all on Labradors. And that was also true of the younger dog study. They had 40 breeds represented. So we're seeing this across breeds, not just the big dogs. So I'm going to reemphasize this. The prevalence of OA in dogs greater than 8 years of age is quite high. The minimum is about a third of them, and it goes as almost up to 60%. So I got to thinking, as a GP, what were a lot of the things that I used to really worry about and talk to my clients about? I talked about diabetes, and I checked for it all the time. So this is a study that from insured dogs, 180,000 insured dogs, 13 cases per 10,000 dog years at risk. That's not as high as what we were seeing in our joints. What about kidney disease? How often are you running lab work on your older dogs looking for kidney disease? Well, in this paper, 25% of the dogs in referral institutions have had evidence of CKD. It's probably much larger because this is a referral institution. So in the general population, primary care, it's probably higher. But still, is it approaching what we see in the joints? I suspect they're similar. And if we're going to worry that much about kidney disease, I think we should be thinking more about joints. What about dental care? Okay, so I'm old enough that I practiced all the way through the 90s. And that's when dental care really became the standard of care. So if any of you are out there of my generation, you know that you've watched dental care explode and has become so important that we talk about it at every visit practically. So a couple studies. The average prevalence of periodontal disease, now that's not just straight gingivitis, I'm talking about perio disease, was between 10 and about 18% when you looked at an awake dog. Now, we all know periodontal disease is subgingival, and so if you anesthetize, you're going to see much more. And so the prevalence there was between 44 and 100%. Now, I find that an interesting range, but that's what they found in the study. So once again, if dental disease is this important, how does that compare to osteoarthritis? Well, I think the osteoarthritis is right up there in terms of concern. So the median age at the first diagnosis of OA was 10.5 years in this 2007 paper. And more than 50% of dogs aged 8 to 13 were diagnosed with OA in 2018. I actually suspect it's higher than that in general. This was a UK population. So I got to thinking to myself, if I'm aware of this, how can I change how I practice? Now, I'm not a GP anymore, but I certainly see a lot of dogs and I can discuss a lot of different topics with my clients. But if I was back to being a GP, what would I start saying to people? What did I talk about in my puppy visits when I was a GP? Well, I talked about vaccines, of course, and I talked about parasite prevention. I talked about toothbrushing, and I talked about training and behavior, and I talked about nutrition. I never talked about the joints. What do I discuss with adult dogs? Well, I talked about vaccines, of course, and I talked about parasite prevention, and I talked about, oh, it's time to clean the teeth, and I talked about we better get some lab work and check those kidneys, and I talked about nutrition because usually they were chubby by then. I never talked about joint disease unless there was an obvious lameness. It was a rare discussion point. So I want you all to think about another idea, which is we know the pillars of preventative care: nutrition, dental health, parasite control, vaccines, but I think it's time we put joint health right in there with the pillars of preventative care. Talk about it at the puppy visits, kitten visits too, for that matter. Talk about it every time you see a dog for a wellness check, over and over and over again, so that our clients also begin to recognize this. Your clients come in wanting to talk about dental health, wanting to talk about nutrition, knowing vaccines are important. We've taught them that. Now it's time to teach them joint health is every bit as important for the long-term comfort and function of their animals. So I got to thinking again, well, what else could we do different? So I ask you guys, how many of you as GPs offer specials during Dental Awareness Month? We sure did in my practice, and if I remember right, that's February. So what if we looked at joint disease in the same way? What if you started offering screenings during May, which is Arthritis Awareness Month? I think that would be a terrific addition to your practice, both helping your patients, but also it's a revenue stream, right? Okay, so let's move on from me talking about how my thinking has changed over the years to how do we use diagnosis with radiographs to help us get through this. So I want you to think about this a little more. Again, this paper I showed you, 40% of dogs over 8 years of age have OA. And at the same time, CT and MRI provide more detail than plain radiographs. Therefore, osteoarthritis is probably much higher than what we're getting with our radiographs. There is a lack of correlation in this study between severity of radiographs and stifle lameness scores. So again, my point is we have prevalence of OA, we have radiographs, and we have CT and MRI. Well, my practice didn't have a CT or an MRI in it, so I could at least use my radiographs. It's an imperfect tool, but it's a good tool that's right there in front of us. So how do we get the most out of a readily available but imperfect tool? That's what we're going to talk about tonight. Okay, so I'm going to start out here by giving you my tips, the things that the radiologist gave me those many years ago, browbeat into me to help me do a better job. And I'm going to step you through these. These are some take-homes. The first is, and I will admit, I did not jump on this bandwagon fast enough. Sedation is a great idea. That's for a few reasons. I grew up as a veterinarian in the era that did not have fear-free. And so I'm embarrassed to say that we would just make it happen. What's wrong with that? Well, one, that's emotionally traumatizing to your patients. And number two, from a diagnostic perspective, you do not get good quality images. And that's what we're talking about tonight. So sedation is a great idea. Use that tool. The next thing my radiologist friend taught me is, whenever possible, one limb per image, with the exception of a VD pelvis hip view, one limb per image. I think, and I did this too, a lot of times we're trying to save our clients some money. We're like, oh, well, if I just put both limbs in there, I can get a good idea of what's going on. Well, the trouble is, you're not necessarily saving them money because you're not really getting great radiographs, as you will see when I give you some examples. You need to do your exam, which is what we talked about a month ago. Isolate, get a focal center for where the problem is, and then get your images focused on that site. Put that area of interest in the center and then collimate. Why do I want you to collimate? Well, when you have a very large area that you're imaging, you have more photons, and as a result, you get scatter and you lose the detail that you want, or if your radiologist is reading them for you, you're losing the detail that that radiologist needs to give you the best ability to diagnose early osteoarthritis. So to get great images, figure out what the problem area is, focalize, then center that in your image and collimate. All right, moving on. When you have long bones, it's okay to include two adjacent joints when you're taking x-rays. If you need to look at a long bone, that's fine. But if we're looking at osteoarthritis, try to get the joint that you're worried about right in the middle. Label your images. As a specialist, I get a lot of images sent to me, and a lot of them don't have labels on them. And gosh, you guys, I know life is busy, mistakes happen, we're human, but try really hard to get that labeling in there. It's so important. Also, always provide orthogonal images. So you want both a cranial caudal and a lateral and sometimes some others. Okay, so don't skimp by only taking a single image. You're, again, not saving your clients any money. You're not giving them a complete study when you only do one image. The other thing is, it's nice to have the contralateral limb in there, but it should be on a separate image. Again, it's that collimation so we don't get scatter, but it's a little more than that. When they're together, when you put two limbs together, it is rare that you can get, for example, the carpus in the same orientation for the right and the left, and that negates the ability to compare them because they're not in the same position. So try really hard not to do that cheater view where you put both front legs in the single image. Oh yeah, and sedation's a great idea. So with those little tips in mind, let's look at some images. Let's give you some tips you can take home for getting really good images. So starting with the paws, and this is actually true for the thoracic and the pelvic limb. When you're doing the dorsal palmar, it's not cranial caudal, it's dorsal palmar view. The important thing is to spread the digits out. So you can either do that with cotton balls. If you look carefully at this picture, there are little cotton balls between the digits. Or you can put a little piece of tape here and here on digits 2 and 5, and then distract so you can get nice spread out toes. When you're looking at digits, when they're all crunched together, that is a really not useful radiograph. So do this trick, it will help you much. What about a lateral view? So I often get an image of a lateral view. Now this is a nice lateral view of the carpus, but can you see much on those digits? Not really. It's hard to tell the individual joints, the PIP, the DIP, a little hard to see the metatarsophalangeal, or in this case, metacarpophalangeal. So that's not the way to get a lateral if the paw is what you're after. So no, not a good choice. Instead, we want something more like this. See how the digits are spread? I can look at each individual digit very clearly. I have to apologize. It's allergy season, pardon me. Pardon me. And that's how you do it. This is the supinated view. You can also do the pronated view, but I've got a bit of tape on each of these toes, 2 and 5, and I've rotated the paw. It's around 45 degrees-ish, and then I separate those digits, and you can get a really beautiful view and compare that to this one where I really can't look at those digits and learn anything. Okay, let's say we want to look at the carpus and the manus. And so what we're looking for here is a straight up dorsal palmar, because we're on the carpus, it's dorsal palmar. We've got a nice label there saying this is the left limb. And then this is the lateral. And in the lateral, actually on this view, we can see that there is some soft tissue swelling right here and here on this particular patient. I have a nice clear view of the bones, and I don't have any extraneous information from the elbow. It's a little, I mean, you can zero in just on the carpus, but most of the time we'll tell you that people will do the carpus manus together. So we also need oblique views. So here's how you set up for a straight up dorsal palmar. And then this is the oblique view. The oblique view lets us get a little different view of these carpal bones. There are 7 carpal bones, and sometimes you need to look at a different view to assess them. More often than not, I'm not doing this on an arthritis study. This is a study where I'm looking for a fracture or something like that. But I want you to know that you can do this supinated view or you can do a pronated view. I will also do special views of the carpus when we're seeing hyperextension. This is a fairly mildly extended view in a normal dog, so it's been extended, but there's no pathology. This is how you do it. You're going to put a little bit of tape on the distal antebrachium, right proximal to the carpus, and then you're going to put some down on the paw, and then you're going to pull opposite directions. And if you have instability, like a hyperextension, that's what you're going to get. So this one is a normal, and this one is an abnormal. Again, I don't always do this in an osteoarthritis patient, but I want you to understand that these special views are very helpful when there's been a traumatic injury. Now, here's one I do use for all my osteoarthritis patients. So when I'm evaluating the carpus, I will do a dorsal palmar, like I showed you. I'll do a neutral lateral, and then I'm going to do a flexed lateral. Why is that? These blue arrows show you. You can see the distal radius very well, and then the proximal carpal bones, and then the distal row of carpal bones really well. And you're going to see some osteophytosis much more clearly off that distal radius when there's osteoarthritis. So this is an important third view of the carpus that I like when I'm looking for osteoarthritis of the carpus. A couple more special views. So we do get collateral ligament injuries. We can get varus and valgus due to the collateral ligament. So in this case here, I've got a medial collateral injury. And so we have done that tape technique, only now I have tape here, and I'm pulling that carpus or pulling that manus to the lateral side while stabilizing with tape here. So this is the more neutral, and this is one with a collateral ligament injury. Okay, so that's carpus manus and paws. Let's move on to elbows. All right. I don't know if you're aware of this. I wasn't when I was a GP. There are 3 standard views for the elbow. I've shown you the first most common, which is a straight lateral, and then a cranial caudal. This is the one that gets missed so often. It's that tightly flexed elbow view from the lateral. And what I'm looking for here is osteophytosis right here along the proximal component of the ulna. And you can see that that can be obliterated here by overlap with the humerus. The more you collimate, the less that's a problem. But this is really considered standard for elbow evaluation. We want a nice clear view here because some of the earliest signs of elbow disease in young dogs is this ulnar notch sclerosis. This is a normal case. The other thing we like to look for on these early cases is this little guy right here. That is the coronoid process, the medial coronoid process of the ulna. We can do a little better job than this x-ray, and I'm going to show you in a second, but first point is 3 views, okay? Okay, let's dig into that coronoid process. So one of the big reasons that we have a high incidence of elbow osteoarthritis in young dogs all the way up to older dogs is because of elbow dysplasia, which there are 3 main types of elbow dysplasia. There is ununited anchineal process. There is incongruity of the radius and the ulna. And then there's coronoid disease, which in my hands is the most common. If you have an all German Shepherd practice, you might see a whole lot more UAPs, ununited anchineals, but if you have a Labrador practice, you're going to see a lot of coronoids, or actually any breed. So how do you get a better image? This is okay, but it's not as dramatic as I'd like to see. So here's your coronoid process. This is a medial view, ulna, radius, humerus. That's a lot better picture of that coronoid process. So what we've done is we've done a little rotation of the joint to get that coronoid process more prominent by comparison to this. So you say, well, how the heck do I do that? It's actually pretty easy. So here's another take home. We want that patient in sternal recumbency. I'm going to extend the limb. I'm taking a cranial caudal view. So the beam is directed from the cranial to the caudal aspect of the elbow. And then you're going to supinate the limb to expose the coronoid process. It might take a little practice for you to figure out how much supination is needed to get this dramatic view of the coronoid, but that's the trick. It's that supination to get that coronoid process away from being hidden by the radius and the rest of the ulna. Cool. What about shoulders? So shoulders, oh, I worked hard on learning this from the radiologist who browbeat me. When we take shoulders, first of all, I want you to notice again, look how tight and beautiful this is. We are focused on this joint. I don't have a lot of the scapula. I don't have the cervical spine. I don't have a huge chunk of the humerus. I am so focused on just that joint. And this is an area where you can get a lot of overlap. So how the heck do you get this isolated so that all we have is some soft tissue? Well, this is the position. The affected leg is down. Dog is in lateral recumbency. You got to bring this head way, way back. And then you're going to extend this shoulder, get it away from the sternum. In a second, I'll show you what happens if you don't. And you can even palpate and go, okay, there's nothing here. I'm shooting directly through the shoulder joint. I don't have interference from the sternum. I don't have interference from the cervical spine. So that is a beautiful picture in the right way to position it. This one, not so much. So that's where the sternum is in the way. So what's happened is, see where the humerus is? It's not pulled forward. It's tucked back here. That is not a useful image because you have overlap or summation. You can't really evaluate for osteoarthritis very well. And also, what if this dog had proximal humeral neoplasia, right? You wouldn't be able to see it very well because you have summation. So aim for this. So that's a no-go. Now let's look at a few others that all of these have been sent in to me. So here's our ideal. This one's overlying the trachea. You know, when I went to school, people talked about this as a view because the air in the trachea gives you maybe a little better evaluation. I don't prefer it. I really like to see this. Here's one where we're overlying some soft tissue. The humerus is out. And this one just has too much in it. I've got the elbow. I've got the entire humerus. This is too much. Collimate. You've already found pain in the shoulder. Take the shoulder x-ray. You don't need the elbow in there if you didn't have an elbow problem. Dog painful there. Just hit the shoulder. So these are not your preferred shots. What about that caudal cranial caudal? So here's a caudal cranial view. I like the dog to be in a boat, but they don't have to be. This dog is only partway in the boat. We're going to put him in ventral recumbency. We're going to extend that shoulder and elbow. And then we're going to collimate so that all I have is this limb and the shoulders in the middle. There is so much going on with the spine, cervical spine on the other side that if you shoot this entire area, you'll get so much scatter that you're going to miss the detail you want here. This also gives you a nice view of the scapula. So collimate, really collimate and extend. Cool. So that is the shoulder, and we have finished the thoracic limb. Okay, moving right along. And if this feels like I'm going super fast, it's because I am. Because we get to play at the end of this presentation with you guys evaluating some images with me. You'll have access to this recording. You can go back through and study what I have. Study the position I have the dog's leg in to get the best images possible. Study my notes about tips. So don't worry if you're not getting all of this right away. Just enjoy the imaging and review it again later. All right, what about the tarsus? So this is the plantar dorsal view. Once again, you're focusing in on the joint that's bothering you. So if you found pain or effusion in the tarsus, that's where we're going to put our beam, put the X on the spot. This dog has a plantar to dorsal view. So we have the dog in ventral recumbency and the leg is extended behind the dog. And here we have a nice straight view. You can see the tibia, the fibula, the calcaneus, the brain just went blank. It'll come to me. Talus, thank you. And then we have the numbered tarsal bones and then the metatarsals. Very nice, crisp, clear image. What about the lateral view? Once again, collimate, collimate, collimate. You can, I kind of put this as a physiologic position so that I can see pretty well if it's overflexed, if it's overextended, we're going to miss some imaging. The vast majority of osteoarthritis is in this joint here, okay? Much less down here at the taloquartile joint or the intertarsal joints or the tarsal-metatarsal. This is where the osteoarthritis mostly is. Most of the time it's due to trauma or due to OCD of the talus. So you want a very clear shot of that joint. Okay. What about stifle? So this is the most common view I get, and it's fine, but this is the surgical view. This is what the surgeon is going to use in order to plan, and all the planning software needs you to have this position for the stifle. So about a 90-degree, a little bit more than 90-degree, and then about a 90-degree of the tarsus, and they're going to do all their planning. But if I'm looking at the stifle or the tarsus, and I want to study if there's osteoarthritis in there, this is not as useful because why? All kinds of scatter from all this extraneous tissue. This is the way to get a really clean view of the stifle. And I've circled in pink where we're going to be looking for effusion from a cranial cruciate ligament injury. But this is also where I'm going to be looking for evidence of osteophytes off the distal patella, near the fibula, coming down here, affecting the caudal aspect of the joint. We might even see some ossification of the patellar ligament. So this is the view you want. Also, you can see a fusion on the caudal aspect here, but that's not what I'm pointing at because there isn't any in this picture. What I'm telling you is you need to align the femoral condyles so they are directly on top of each other, no obliquity. Same goes for the fibula. See how they're right on top of each other? This is a pure lateral view. This one is not. Do you see the obliquity? Do you see how the cause of the femur are not on top of each other? And we have separation of the fibula. You also can't clearly see, here you can see the fibula, and it's not clear there. In a really good shot, you're going to see the fibula and the tibia. So this shot is not a good one. Okay. So you need to decide if you're going for a diagnostic view or a surgical view. What about the cranial caudal view? A lot of times I end up getting stifle images along with the hip image or the pelvis image, and that's fine. But if I'm really trying to study that stifle, I'm going to collimate down so it looks like this. I don't have a lot of extraneous tissue with the femur and the distal tibia. So dog is partially in a boat, that's helpful. Then we're going to extend the hip, extend the stifle, and then internally rotate that distal limb in order to get the patella right in the center. And now I have a really pretty view of the entire stifle joint. And here I'm looking for osteophytosis across the tibia and the femoral condyles will also be periarticular fibrosis here and here. Okay. Speaking of the pelvis, how do we get pretty pictures of the pelvis? This was one of the hard ones for me. This is a big take home. How do you get a really nice pelvis picture? This is the key. Do you see this little pad here? So what's happening here is we have elevated this up leg so that it's not falling down onto the table. Because when that happens, you pull on the pull on the femur, which pulls on the pelvis, which creates pelvic obliquity. So the key is to make this femur and the down femur parallel to the table, parallel to each other. Don't let this up femur fall down towards the table. And then, if I'm looking at the pelvis, I'm going to collimate into this pelvis view. That's what I want. Now, this isn't going to give me as much information about the hip joints. A lot of times, this image for me is distinguishing hip dysplasia from lumbosacral pain, because as we talked about in my last lecture, clinically, you can separate those out with your exam, and then you're going to prove what you found with imaging. So how do I get a really pretty lumbosacral view? I align the dog like this. I put my beam directly on this part of the pelvis, and now I've got a beautiful shot of the lumbosacral region. So there's L7, and there's the sacrum, and I've got a nice straight shot there with no obliquity. That would make it difficult to interpret for lumbosacral disease, distinguishing it from hip osteoarthritis. How do we get the traditional view of the hips, which we've all done the quote unquote A viewing? So what we're looking for here, a boat helps you again. We want a very straight lumbar spine, actually all the way to the thoracic spine. And then we need to internally rotate the femurs. You don't have to use tape if you're in the room. This is a picture from a practice where you're not allowed to be in the room. Again, the label is there, and this is what we're looking for. We're looking for parallel femurs, symmetrical obturator foramen. So let's dig into that a little bit more. How do we get really pretty pictures? Because I think we all learned this position, right? But yet I still get images that are not quite right. So why is that happening? I'm gonna tell you, number one is probably sedation. You didn't sedate the dog. The dog is uncomfortable. They start struggling, and then you just take the best shot you can, but it's not as useful. So let's talk about it. First, sedate the dog so you can get really pretty pictures. Next, position the dog, and then critically look at what you got. So over here, image A here, I'm looking at parallel femurs. So I've got these yellow marks showing you a beautiful parallel femur. And then I'm gonna look at the obturator foramen. Are they symmetrical? So I'll take that away. That's pretty close. And then there's this next spot. I have no idea what this is called. I don't care. I just want to know that they're very symmetrical. And then the next thing I look at is the proximal wings of the ilium. So up here at the top, is this line parallel? And then the last thing is looking at the face of the ilium here. How much exposure do I have of the wing of the ilium, and is it symmetrical on both sides? So here's a white line showing you that and that. So this, when I'm looking at my pelvis views, so that I don't misinterpret hip alignment when I'm looking at early disease potential, this is what I'm looking at to make a beautiful picture that I won't misinterpret because of alignment. So if I look at this one here, I go, okay, well, the femurs are close, pretty close, but you got an optical illusion of the picture actually crooked. So I'm still going to evaluate it. Femurs are pretty straight. Obturator foramens, pretty good. Whatever the dickens this is called, also pretty good. We've lost the proximal edge of the wings of the ilium, so that's not ideal, but it's not terrible. The face of the ilium is pretty similar. So I look at all that and go, okay, even though it's crooked on the frame of the picture, the body is pretty straight. So now I start looking at the hip and I go, hey now, that looks subluxated. That looks better seated. That looks subluxated. And now I can actually say maybe it is because my picture was good. My image was good. And that I didn't create that because of poor alignment. Now look at the next one over. So we'll start with the femurs. Oh, those are pretty straight. That looks pretty good. I'm all right with that. Uh-oh. The face of the ilium on the right side is not the same as it is on the left side. So right away, I know that pelvis is crooked. And sure enough, the obturator foramen are showing me the exact same thing. And so now I know that anything I try to interpret on this image, I must interpret with caution, because it is not well positioned, and I would try again. Okay, so this one, even though it's crooked in the frame, all of my markers were correct, and I am suspicious this dog has subluxation. This one, it looks like the dog is pretty good, but I can't fully interpret because it's not aligned. So for pelvis views, you've got to be super picky. Let's talk again about the lumbosacral space. So I showed you how to position for this. I want you to put that X right on the LS space. I want you to elevate this up leg so it's parallel to the table. This is not a good shot. We have scissor legs, and we have the wings of the ilium completely obliqued. And if you look here, it's very difficult to interpret that lumbosacral space. That's a bad one. This is a beautiful one. I already showed you that. So here are the two wings of the ilia, perfectly aligned. Okay, and now what a lovely view right through that lumbosacral space. Again, the reason this is important to me is I have to distinguish hip dysplasia from lumbosacral disease. So in this shot, two different dogs, but this is a neutral shot for the lumbosacral space. It looks pretty clean. There's no wedging of the lumbosacral space. I don't have any ventral spondylosis, and I don't have any compression from an ossified or fibrous dorsal ligament. When we look at this one, now I've extended the dog and I've created a wedge. See that wedging? That's lumbosacral disease. Not all dogs with ventral spondylosis do this. So this is not diagnostic of lumbosacral disease. We need to look further and look for that wedging. There's also sclerosis here, sclerosis there. This is a dog with lumbosacral disease. So if there was pain on extension of the hips, and yet my radiographs looked pretty clean on the hips, then I would be thinking, my patient has lumbosacral disease and not hip osteoarthritis. Okay, so we made it through all the tips and clues. So what I want to remind you is that this is available to you to go back through and review and review and review, and work on your skills in aligning the patient and being critical of the images you get. So this next section, I want to have you start practicing. I want you to judge some pictures and say, okay, is this what I want? Or what could I do to make it better? So I'm going to open up the chat. In the first few, I'm going to go ahead and I think I'm going to open the chat. Perhaps not. Hey, Meg, my chat isn't opening, so I might need you to help me.
I got you.
You'll be telling us what people are saying. So the first few, y'all, I'm just going to tell you what's up with the pictures, and then the next ones I'm not going to tell you, and you guys are going to think about it. So let's do this first one. So this is a image that was sent in to me. Dog who has discomfort in the pelvic limbs, and right away, my brain says there's too much in this picture, right? What are they going for here? And that having so much in there means I've lost some detail. I've lost the resolution that I can get when I collimate. I will say that I'm not sure that this is the right. It could be the right, it might be the left. And so how do I know? And then the next is, look at these tarsal joints, you guys. What is the benefit of putting both of these in here if I can't compare them? This one has a degree of valgus to the joint, and this one has a degree of rotation to the joint. So putting them both in there didn't help at all. The tail is up here, and if I could see the stifles, they're way, out of the picture. This one has so much summation, I can't see anything, and this one is obliqued. So this image, probably the best thing I see on this image is this one, because it's the most properly aligned. But the client paid for this, and we're going to interpret it as best we can, but certainly I think we can do better. That's what I'd like to see. Okay, so comparing this to this. All right, next one we'll do together. What are we going for here? I'm not sure. Is it the cervical spine? If it's the cervical spine, I think that collar should come off, right? And if it's the shoulders, they're not in the same position. They have so much summation here that it's not crisp and clean and well detailed. The elbows also have a tremendous amount of summation here. So honestly, to me, this image has nothing of value to me in it. I can't trust anything I interpret in there. And the client paid for that. What should we do with this one? Once again, what are we going for? Are we going for elbows? Are we going for the carpus on the right? Are we going for the manus on the left? You can't compare them, right? Because we've got obliquity here. This one's fairly well aligned, but it's on the edge of the view. The technique, this is overexposed, this is underexposed. I've got the elbows. This elbow, the right elbow, is underneath the humerus of the left. There's summation of soft tissues with this elbow. So interpreting this elbow is really challenging. They've got labels, which I love. That's fantastic. But we've got obliquity, different angle joints, too much in the picture. We can do a better job. This one just came to me this week. Once again, what are we going for here? I have, and I will tell you, this came from a specialty hospital. So I've got the heart, and I've got some lungs, and I've got some sternum, and I've got the humerus, but the technique is not so great for that. So I think they were going for elbows. In fact, I know, because I know why the patient was referred to me. So this is pretty good radiographic technique from the MAS and the KVP, but I can't really compare these two elbows because they're not in the same alignment. I've got the entire antebrachium here. So I think we could do better than trying to put both joints in there. Because if I'm trying to compare right and left, I really can't. It's not very useful. Okay, now it's up to you guys. Take a look at this. And if you want to participate, throw a few comments into the chat for Dr. Green. And then we'll compare with what I have. And I think we can take, I don't know, 20, 30 seconds for you guys to kind of read it and throw some things in there. And Meg, let me know if you have some brave souls.
Not yet.
Not yet, okay. That's all right. You could be anonymous if you want to, too. It's okay. I'll give you the first hint. There's too much in this picture. If we're talking about osteoarthritis, an abdomen is not what we want. I see Christy had a comment. Meg, you've got anything there?
I am seeing right now, it's saying that the chat is disabled. Amy, could you assist us with that, possibly?
What's going on?
The chat is
Chat is
disabled.
disabled. That's why I couldn't open it. There you
We
go.
can actually take people that raise their hand off mute. I did see we had a hand raise, so if you all would like to raise your hand, I'm more than happy to take you off mute and let you answer as well.
That works.
If you want to also put it in the Q&A, we can put it in there as well.
Christy Carlo, you can answer as well.
Can you hear me?
Yes, we can.
Hey, Christy.
Hello, how are you?
I'm great. How are you?
Good. Yes, I agree that there is too much in this film, whether it's abdomen or whether it's the femur, the hip, the stifle, the spine, the LS. It's hard to know what they want.
Yeah.
You can see that there's some early spondylosis at
Mhm.
7, 6, 5, 4, 2, 3, 4 area.
Yeah.
But other than that, you can't see anything.
I agree with you completely, Christian, and I do note the ventral spondylosis. What I don't know is there any narrowing of the disc base that could be causing some of the mobility problems that I think might be arthritis, and instead it's disc because it's not positioned properly to look at disc space. Certainly when we treat patients that we suspect are uncomfortable, we have to distinguish neurologic from orthopedic. So if that's what they were going for here, we just need to improve the image a bit. So let's see what I wrote here. I wrote, what are we going for? Too much in the image, scatter. So that's the big mess there. I mean, I threw this one out as a glaring example of too much. Okay, let's do the next one.
And as a reminder, you can raise your hand or answer in the Q&A box.
I'm going to give you the first hint. Too much in this picture.
We have one response that says joint of interest is not isolated.
Love it.
Shoulders overlapping soft tissues.
Yes, 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 yes.
Scatter, not collimated. Trachea
Yes.
superimposed.
Yes.
Too much in the film. No labels.
Yes, I was waiting for that one.
Lack of focus on the desired joint, and you can see both shoulders.
You guys are killing it. That's exactly what I had. Were they going for the shoulder? I'm not sure. Which one were they going for? No label, scatter limits structure, scatter, let's just say scatter, and then summation. You guys hit every one of them. That's beautiful. I want you to know this again was an image that was sent in to me, and I'm not trying to bust on people. I'm just trying to be kinder than the radiologist who taught me and show you how to do it differently. That's what it should look like. Look how lovely that is compared to that. Can you see the detail? I mean, look how gorgeous that is. You can see so much detail here, right? Ah, just yummy. And then no detail because there's too much there. There's scatter. All right, let's do this one. We already know the obvious, too much in the image.
Question mark, chest film, shoulders, good label.
Yes.
Too much.
Brilliant. Yes. What is this? What are we going for?
Rotated, underexposed.
Yes. Although that this was sent in for shoulders, y'all.
Is the label correct?
What do you think about? Yes. I was just going to say it. You guys said, is that label correct? It's a little hard to tell because it's so rotated that the heart has swung. And so it's a little hard to tell which is right heart, which is left heart. So shoulder, it's not in the center. Label, is it really the left? Scatter. You hit them all. That's brilliant. This is what it should look like. Lot better detail, but you will notice that there's so much that goes into a craniocaudal shoulder that the detail's not as clean as a really good lateral, but still so much more I can see with that shot. Okay, what about this one?
No label to distinguish sides.
Correct?
Needs better extension of the limb.
Yep.
Not focused on one joint and it's rotated.
Yep.
No label. Is that 2 legs in one view? Need an orthogonal view?
Yep.
Asymmetric alignment.
You guys, you hit every single one of them. Too much in the image, no labels. I can't compare right and left to the limbs because there's obliquity and differences in joint angle. You didn't miss a single thing. So what would be better? That. You've isolated it with your exam. You know you want an x-ray of that elbow. You get a really pretty image. Fantastic, you guys. All right, what about this one?
No label, not collimated, not focused on the joint of interest.
Yep. See the theme? Same thing. Elbow's not in the center. There's so much scattered. Look at this image. Because there's so much scattered from all the soft tissue, you've lost the detail in this elbow. And look how sharp everything is here compared to with all this scatter, how you lose the detail. What about this one? I told you everything already, including a human finger. So let's take it through. Once again, too much in there, scatter, there's no label. The carpus is neither flexed nor extended. And what? Don't be that guy. So this is better. Now, I don't love that there's a catheter there, but if I'm looking at the carpus, this is a really pretty image of the carpus. And then remember what I told you, when I'm looking for osteoarthritis, get that flex view. Very useful to look at the distal radius. What about this? Same thing, too much in the picture. What else can you say about it?
Not centered or collimated.
Mhm. Look at the stifles, this one and this one. What do you see?
Obliquity.
Yep, obliquity. So I can't really interpret this one very well. What about this one? So is this the prepuce or is that a fusion? I think it's the prepuce, but you've got overlap of the prepuce and the os penis on the fibella over here. So it's on the edge of the film. We've got summation of other structures. So if I was going for the stifles, I really can't say a whole lot about either, except there's no like glaring end stage osteoarthritis, but it's definitely not a really crisp diagnostic image. Okay. So that's what it should look like if you were going for the stifle. And if you're going for the lumbosacral, that's what it should look like. What about this one? Remember how I coached you on looking at pelvis images?
It's crooked.
Okay.
Misalignment.
Misalignment of the femurs, you mean? I agree with that. Should be parallel to each other. What else? What do you think about those obturator foramen? Not the same, are they? Look at the line across the wings of the ilium. Look at the face of the wing of the ilium.
It's rotated.
Pelvis is oblique or rotated, yeah. Yeah, so if I was wanting to really, let's say this is a very young dog, I'm trying to say, does this dog have evidence of hip dysplasia? Not necessarily hip OA, but hip dysplasia. This image will not tell me that. And of course, we will say that these images are not the best way to figure out hip dysplasia. A pen hip is, but if this is what you got, let's make the most of it. What about the stifles? What do you think about those? This one is more flexed, right? This one is more appropriately positioned. Patella is in the middle of the image. Patella is more lateralized there. So the big thing here is this is not properly aligned. The right hip is flexed, and then we have obliquity to the hip or to the pelvis. Okay. What about that one? The boat's right in the way, right? So you have the line of the boat through the image. This pelvis is fairly square. It's not bad. The obturators are a little off, so I'd want to improve that, but it's close. But these femurs, they are pointing up towards the beam because the hips are not extended. So hips not extended, femurs not parallel, and there's no label. This is what they should look like. Remember what we talked about. Parallel femurs, obturator foramen, very symmetrical, whatever this is, very symmetrical. The face of the ilium is equal. What do you guys think about this one? What can be improved? Don't break my heart now. What must all elbows
Add a
What?
hyperflex view. Add a hyperflex
Yes,
view.
bingo, there it is. These images are really pretty. They're really nice, just missing the hyperflexed view. Brilliant. What about this one? I get this shot all the time, super common. So the obvious is too much in the picture, right? Also, this one has a slight valgus to the carpus, so that's going to cause some overlap here. This is more appropriately aligned. It's overexposed for the manus, so it should be. And also, is the label correct? We're not sure about that, so similar. So that's what it should look like.
Toes are not spread out was another comment that was made.
Yes, somebody got that one too. If we were going for the digits, they're not spread properly. Beautiful. How about this one?
Too much in the image.
Mm-hmm. What about the position of the carpal joints? Do that versus this. So they're in different positions. You've got a different level of obliquity to the right and the left. So once again, one joint, one limb is really the key. This is one that came in today. What do you think of this one? I didn't talk about this, so this is for extra credit. It's a pelvic limb, if that helps. So I'm going to tell you where the pathology is. Do you see the swelling of this digit right here? This digit right here is swollen. This is the soft tissue margin of this digit. Which digit is it? You're right. I don't know either. So this is a pelvic limb. We have 4 digits. It's labeled left. That's brilliant, but medial and lateral aren't labeled. So this came in and I said, well, you have a swollen digits. It's either 3 or 4. I don't know. You see that? Okay, and this one is just a gimme. Don't be this guy. Don't do this. Okay. So these are some references that I've provided for you, some great resources for positioning, and I took some of my pictures from these to show you how to position, and some nice textbooks. So with that, I want to open it up to questions. Meg and Amy?
Thank you very much, Patsy. It's greatly appreciated. Everything you went through is, so thorough. And what I really appreciate is the fact that you make it so simple, for us to be able to, go through each of the joints themselves and identify, proper positioning and really make it practical. And I think just the tips that you've shared along the way, as far as the collimation and really how much, clarity that brings, and allowing us to focus on that specific joint, and be able to do that along with the other tips and tricks that you've shown us, really is a great way for us to get that better diagnostic imaging, for us to be able to really appreciate the pathology that's going on.
Awesome. Thanks, Meg.
Absolutely.
Like I said, I learned it the hard way with someone being really hard on me.
So one of the things I would go back to, and I think at the beginning of tonight's lecture, that I think as we get people thinking about some questions, as we don't have any that are in the queue just yet that I can see, is going back, just generally speaking, in regards to the study that you presented on dogs, under 4 years of age. And looking at the pathology there, one of the things that oftentimes we, as practitioners, as we've seen, is like how much we oftentimes overlook, talking about joint disease in those young dogs. And so one of the things I wanted to ask you about is more, if we're looking at, say, a 40 kilogram, 2-year-old lab, and you're starting to see some changes in that dog, maybe it's, showing some evidence to the owner, but at the same time, maybe they're not noticing that. What are some early things that you say with regards to management as well as treatment, when you're talking with, those owners?
So you're saying that I already have a suspicion that there's a joint showing early osteoarthritis?
Yes.
I'm gonna pick on the elbow because you picked a Labrador.
Okay. Sounds great.
So going back to the talk I did last month, one thing is go in with a high level of suspicion always. And so given that breed, I'm always checking elbows and I'm checking hips and I'm checking tarsal joints because of the breed. And I'm feeling for any effusion, and creating my level of a suspicion, and is also looking at gating and all that, and then doing my examination of those joints, putting them through range of motion, doing my special tests. And if I am suspicious, then I'm going to talk to that client about getting really good quality imaging. Let's say I made my diagnosis. Now I need to talk to this client about how to treat osteoarthritis in the short and the long run, because it's going to progress. I'm going to have more success in keeping this dog comfortable and functional for longer if I attack it in a multimodal way. And so I'm going to start by discussing proper nutrition. Again, Labrador, Labrador, Labrador. So keeping that dog slender and fit with the right amount of protein and the right body condition and muscle condition score. I'm going to talk about the proper activities. If it's a dog with elbow disease, I'm going to talk about let's not let that dog jump out the bed of your truck, or, you know, off out of the cab of your truck, landing hard. So activity modification. I'm going to talk about NSAIDs if they make sense as a palliative therapy, but that's not going to impact slowing progression of disease. And so I also want to be talking about ways I can slow progression of disease, and that's with the activity and the nutritional modification. And then I'm going to get in there with targeted therapy. And this is where I'm going to start doing joint injections. And in a young dog like this, I'm going to reach for Arthramid, and I'm going to get it in there as quick as I can. If the dog goes and gets scoped, I'm going to go after it with Arthramid a few weeks after the scoping. I don't do it at the same time. There was a paper that came out that there's a certain percentage of our injectates that can leak out if we do it at the same time as scoping. Now, Arthramid is really viscous. Nobody's looked at whether it'll leak out at the same time as arthroscopy, but to be safe, I do it 2 or 3 weeks later, or a month, or what have you. So to me, it's that multimodal approach, but then I'm going to get really targeted to slow things down with an Arthramid injection, at least in my hands.
We have some questions that have come up since we've been discussing. It says, one thing is, what is your standard protocol for sedation for radiographs?
Oh, yeah, that's a really good question. It depends on my patient. So if we're going to have a young dog, and it also depends on the temperament of the dog. So if I have a young dog, I'm going to start with some basics like maybe gabapentin and some trazodone at home. And just see how much that gives me. If the dog is still pretty nervous or uncomfortable, then I might add in some injectable butorphanol. It's one of my faves. And if I really need to have the dog much, much quieter, let's say they're very uncomfortable, I'm going to add in a little dexmedetomidine if it's a young, healthy dog. So I call myself a mixologist as an anesthesiologist, and then I put an umbrella on the top, right? So I'm going to do a little of this and a little of this, see where we are. And then if I need to, I'll top up a bit. So starting with orals at home and then top up as needed with injectables.
Excellent. So the next question that we have is in regards to positioning. Do all of these tips also apply to cats?
Yeah, pretty close. Yeah, I would say that's true. You want that similar alignment. I'm just thinking some of the, like, we don't have coronoid disease in cats, so that doesn't really apply, but all the others really do.
Okay, back to our previous question. In regards to what injectable might you use in a senior dog? Do you have a different protocol for a senior dog?
Yeah. So again, I want to know, what organ function is. So that's not only for sedation, but also for medication planning. And if I'm going to do injections for sedation planning and all that. But I'm going to pick a dog who's not overly uptight. I may say, let's do some gabapentin and/or trazodone at home. That's a nice starter. And then I'll use injectable butorphanol. If I'm worried about cardiac health, or if it's a really geriatric animal, I'm not going to reach for that dexmedetomidine, even though I love that drug. I won't reach for it in my really medically compromised or geriatric dogs. I'll top them with a little propofol if I need it. Most of the time in that geriatric population, unless they're really, really scared dogs, butorphanol, traz, and GABA, some combination of that is usually sufficient. And they're lightweights usually. It doesn't take as much.
All right. So the next question is, if you are interested in taking your awesome advice on OA Awareness Month and screening, how would you recommend you perform an OA screening set of images? Take focus views of each joint, or just based on your palpation and your physical exam?
Exactly. So if I was creating this, let's say I was back in my GP world, I would be creating, like, I'm not sure about how much time, like a 30-minute appointment where we evaluate the dog like I taught you guys last visit, where we go over looking at all those appendicular joints for effusion, muscle atrophy, decreased range of motion, all that stuff. And then be able to have that conversation with the client about, okay, I was able to focus on your dog has pain in the right stifle or pain in the left hip or what have you. I wouldn't just start taking x-rays. I like to be super targeted and say, this is where I'm worried. So use your physical assessment to then say, Mrs. Jones, this is what I found, and I would really like to bring Buffy in to take some sedated radiographs. And then I want to talk about how to treat osteoarthritis for your dog to help her in the short and the long term.
Okay. The next question that came up was, what are your thoughts on using midazolam for sedation?
Midazolam. I'm assuming they mean as an injectable.
Yes.
I don't use it much, and that's because you can get adverse response, so the opposite of what you want. So sometimes with midazolam, I'll get an excitable response. And for me, I want something super predictable. And I don't get weird responses very often with the medications I told you. So while I like midazolam, I usually use that for induction along with something else like propofol, for example. I don't use it for these short sedation protocols personally. It's not as predictable for me.
So another question that comes up, this isn't in our Q&A per se, but one question that comes up a lot that I have with practitioners is, how do you get owners to become more aware of going away from just where they're noticing it in their older dogs, to be able to say, what are some clinical signs that they may see in that younger dog, with regards to early onset OA, between say 2 years of age and 5 years of age, so that we're not
Yeah.
waiting until they are older.
Yeah. Oh, I love that question. I think this is a work in progress, and I think building awareness is where we need to be so that the clients are more often coming to us. So building awareness means talking about it at every puppy visit and every wellness visit, every single time. So they start, pretty soon they're coming to you going, you know what? I'm noticing whatever. So things that a client may see at home. Behavior changes. Dog is not willing to jump on the bed. When it's a young dog that should be able to jump on the bed. A funny sloppy sit in a youngster. In my last presentation, I showed you some pictures of a young Labrador sitting in a really not appropriate way and wasn't able to correct itself. I would say clients could be looking for not as much endurance. That's the kind of stuff. Honestly, to be fair to a client, unless it's a really dramatic issue, and with that, I'm thinking really bad hip dysplasia or really bad coronoid disease, a lot of them are not going to pick it up until it is arthritic and the dog is limping or the dog isn't going as far as it should on a walk. That's why I think it's you guys putting it front of mind so that you're looking at all these joints every single time.
How would you, in regard to just that, looking at these joints every single time, say you have a client that is used to having, say, their older dog, their more senior dog, that they have been accustomed to getting NSAIDs and rest and therapy that way. Talking about some diets, there's still some multimodal approach, but maybe not a targeted therapy approach in those dogs. How would you advise practitioners to start to have that conversation, being able to see, like, utilizing this diagnostic imaging that we've seen tonight, and then start to have the conversation, bridging that gap between utilizing rest, NSAID therapy, nutrition, and then starting to have more of that conversation of bringing in targeted therapy, whether it be in a younger dog or whether it be in an older dog.
So are you asking me, when do I start talking about targeted therapy?
Mm-hmm.
Yeah.
Yeah.
Oh gosh, as soon as I think there's arthritis, whether it's early or late onset, I'm on it immediately. So for example, I just injected a dog yesterday. I believe she's 18 months old. I diagnosed her with elbow disease. The day that we worked her up for her elbow disease, I talked about multimodal all the way through targeted and said, and I want you to go see the surgeon for discussion about arthroscopy. She was scoped. She had 2 fragments removed. And I prepared them on my first visit to say, I'm going to want to do targeted therapy, whether you get scoped or not. If you get scoped, I want to see you in 2 to 4 weeks to follow up. So it's right away.
Excellent. Well, I think that's, let me just double check the Q&A. I think that might be all of the questions that we have right now. Thank you so much for your presentation this evening. One thing I wanted to make everyone aware of is that we've got some exciting news. We have coming up a JAVMA article that's just recently been accepted, talking about owner-reported safety and efficacy of the 2.5% polyacrylamide intra-articular injections in dogs with osteoarthritis. And this was a survey retrospective study that was done with 100 owners with over 150 joints. And so I think a lot of the things that we've talked about tonight, one of the biggest challenges I think is getting owners on board and being able to get them to think about radiographs, being willing to sedate their dogs, and then really what's the next step is that treatment. And so that sort of leads us into our next talk that we're going to be having coming up. And I'm going to turn it back over to Amy, and she's going to share more about the next webinar that we're going to have. Thank you all so much for coming tonight.
Thank you again, everybody, for joining us tonight and for your participation as we went through those radiographs. Dr. Mich, thank you so much for your expertise, not only with our part 1, but part 2 of this series. As a reminder, you all will receive a recording of this webinar and your CE certificate in the coming week. And please also join us for our last webinar of this summer series titled Canine Joint Injections, Why Should Horses Have All the Fun? And that will be September 4th at 7:30 Eastern Time. So thank you again, and we hope you all have a wonderful evening.
Thank you so much for listening. I'm very grateful for your time.